Hello, everybody, and welcome to the AHA podcast, Advocate Health Advisors. It's our third consecutive week now of putting out new content. And I'm going to start off with some of the meetings we had with CMS and some of the current things. So, Jacqueline, let's go to you first. What should agents be doing now? Because we just had some refreshers on the scope of appointment, and I think that's a good place to start.
Yes, absolutely. So I know this is the time now where a lot of agents start preparing for AEP, ANOX season, and so agents are getting ahead of the ball early. And they can start working their scope of appointments, which are good for 12 months for the product line that you wish to discuss with your members. And I know Alyssa is planning to talk more about that memo that was just issued by CMS recently as well. And also some good topics for agents today, as we're hearing some updates for 2027 from the carriers, reading some tea leaves and some good practices agents can take away today.
Thank you. Yeah, we found out about the scope. Alyssa, you want to tell us a little more about that?
Yeah, happy to. So, CMS added some new guidance regarding scope of appointments in the final rule. However, I think there was still a little bit of ambiguity when it came to some of the more specific details about scope of appointments. Um, so, what they sent out yesterday, they published a memo May 26th, basically trying to clear up any confusion that agents might have relating to the scope. So, for example, the 12-month scope of appointment validity period still stands. So, if you were to get one today, it's May 27th, it would be good for 12 months from today. So, if you got one today, you could use it for AEP that's coming up. It would still be valid, so long as the product types are still the same that you're going to discuss during AEP. So whatever you check on the scope of appointment, whether it's Medicare Advantage, Part D, Medicare supplements, as long as that's the same during AEP, you can still use the scope that you got signed today. Another thing it clarified was it doesn't just have to be a written paper scope. It could be an electronic scope. It could be a recorded scope. So if you have it on a recorded phone line, or if you're doing a Zoom or something and you have it recorded via audio, that's perfectly fine as well. So those are some of the things that it clarified. But basically, the 48-hour period, as we know it, it's going away. So effective October 1st, that 48-hour waiting period is waived. You still have to get the scope, and that's something I really want to stress to agents. Scopes aren't going away. It's just that 48-hour waiting period is going away, and the scope is valid for 12 months. And there's a variety of different ways you can collect a scope, whether it's electronic, verbal, or paper.
Yeah, thanks, Alyssa. And I would recommend that people start collecting those now because
Mhm.
we're expecting a continued disruption. We're not out of the woods yet with plan value. In fact,
Mhm.
Jacqueline, didn't you see some news from Humana and what they reported to the street?
Yeah, absolutely. I think, now some, a lot of plans filed their bids and are continuing to do so next week. So they're coming out in investor meetings and some presses with their, reading the tea leaves for 2027. I know Reuters posted an article summarizing this, and I think generally they expect industry-wide across plans to kind of curb back on some of the supplemental benefits. Overall, I know Humana is having some more of these adjustments more significantly, with some more curtailing of these benefits, and they're open about it. Which was good. They're just letting agents know early that they plan to reduce some of these benefits too. And looking ahead for 2027, they really want to strengthen some of their star ratings, quality bonuses, and they're looking ahead for 2028. So right now, we're actually shaping 2028 star ratings. And moving into 2027, we'll be shaping 2029. So that's how plans plan to more differentiate there.
And Alyssa, don't we have some more news coming with IRA? There's another round of drugs and some more changes that kick in 2027. right?
That's right. That's right. So the IRA, the effects are still going to carry on into 2027 and even into 2028. We're going to see some changes down the line with, like you said, in addition to more drugs that are capped at specific costs, as well as the max out of pocket for prescription drugs. We're going to see that capped. It was $2,100 for 2026. And so we'll see that come out for 2027, what that cap is going to be for the max out of pocket. The M3P, or that spreading out of the prescription drug costs throughout the year, is still going to continue into 2027 for those agents who have clients that benefit from the M3P program. That's something that levels out their high cost prescription drugs throughout the year just to make it easier for people to pay. And we're still going to see that into 2027. So that's good for people with those high cost medications.
Yeah, thank you. Jacqueline, I saw some big organizational announcements, MedPAC and others, so the CMS as well.
Yeah, so MedPAC, they're set to appoint a new chair this year, and they just announced that over the weekend. So the outgoing chair, Michael Chernow, is now being replaced by Amal Navith. And so I think overall this is more favorable for us. We know, MedPAC tends to be a little bit more skeptical towards agents and brokers, and some of their data and studies have a little bit been skewed. And I think Amal offers some good insights. He sits on a health plan board of directors as well. He seems, very well rounded there, and he's said in previous meetings too that he thinks agents and brokers provide valuable information to beneficiaries. So that was a move there. And then they also appointed 2 new members, reappointed a few members too. So there were some shifts happening. Also, CMS did make a couple of movements. So Stephanie Carlton, which was previously both deputy administrator and chief of staff. Now she can focus on deputy administrator. The new chief of staff now for CMS is Rebecca Armstrong. And she also is a very relevant, I think, pick for our industry because she has a lot of experience working with the carriers and on the Hill, having come from AHIP and working in federal affairs there. So I think, there are some really relevant appointments happening in a positive way.
Yeah, yeah. And it's transformational in some ways because we were just talking with the Medicare Collective the other day, and there really hasn't been a industry voice where all the different leaders in the industry get together and share ideas and then speak to CMS. And so not only are the leaders at CMS making themselves available and putting their thoughts and visions out there, I was just on a call today with a lot of the staffers. They make a bit of a differentiation between a political appointee and and a more of a career or full-time person. And so there's a lot of unity of effort in the organization, and the rulemakers are also speaking directly with brokers in the field and being informed by that experience. Speaking of informed by brokers, Jennifer, what is the juice? What are you hearing on the street? What are the brokers talking to you about on the phone these days?
Well, thanks for asking. Well, first off, I mean, all of this information that you guys are working on and finding out like real time from, CMS and through the Medicare Collective is awesome because that great work allows me to put agents and agency owners' minds at ease because, they're nervous, right? They know and they see, the plans becoming non-commissionable and the carriers making reactions and things like that. And so, first of all this is positive news that's happening, and that is very proactive work. And to know that, they're favorable towards brokers. That's what the message I keep sending out to the agents. They are nervous about non-commissionable plans still. They're nervous about coming into AEP, anyone with a really large book of business. But to you guys' point, with the scope of appointment rules being relaxed and also the fact that they can be proactive, a lot of the talk now is about how to prepare today for your AEP. So if you're an agent that has a really large book of business, there's nothing stopping you now from making sure you have those scope of appointments and making a connection with your member. It's a good time to check in with them and be ready for that AEP. And, we're here to help too. We have a lot of, we call it our ANOC book of business catalogs where we can help do that. Jacqueline's team does that. So those are the things that I'm sharing. I'm just trying to put their mind at ease. That's the latest and greatest. I mean, if, a lot of talk about ancillary carriers and products, to the point, where these carriers are being very open about maybe having to make their plans not have as much dental or, trying to be more profitable. It's an opportunity to look to see if there's other things that you can pair with that for your member too. So I'm having a lot of conversations and we're adding a lot of, real specific ancillary, maybe hospital indemnity, maybe a dental product, something like that. So we're working with agents to get ready for that. And then, of course, what's the date, Alyssa? The AHIB's about to open. I mean, we're already here.
Yes.
We're at the end of May. So
Yeah, I think it's right around June 23rd, and that's when we're seeing carrier certification start to open. AHIP is usually a little sooner. So AHIP is usually maybe a week or so. They take it offline and then they release the new upcoming year AHIP certification. And then some of the carriers have already announced what their recert windows are going to open up. And in fact, for one of the carriers, I just got an invite today to register for a certification sneak peek. So we can see kind of what their portal is going to look like. And it's a big carrier, so it's going to affect a lot of agents. I don't think it's a major change, but they're giving us a little bit of a heads up so that we can support the agents as they work through those certifications, because we're literally a month away from those carriers all opening.
Oh,
And it
Alyssa,
only
too, I
gets
was
busier, right? It only gets busier.
That's
If
right.
you
Yeah,
wait till August, you're behind.
That's right. So we jump on it as soon as AHIP opens up. Here at Advocate, we're licensed agents, so we go through the AHIP process as well. So we try to jump on it as quickly as possible to get it done, so that way we can guide the agents through it. And then, of course, as the carriers kind of stagger their recertification windows opening, and then, we go through that process as well, because it'll be September, October before you know it.
Yeah, you and Jennifer keep beating me the last couple of years. I can't. You guys get 95s and 100s. I'm barely getting my 90, I think. Jen, you were going to
Yeah.
say something?
Oh, I think we talked about this on one of the other podcasts, but Alyssa, I think it's good to bring it up again because one of the other big changes that CMS made was on that sales seminar versus educational seminar that you can
Yes.
do. Tell us about that again, because I think agents will want to hear that.
Yeah. So just a reminder, in the final rule, one of the good things that happened is that they removed the 12-hour buffer between holding an educational event and a sales and marketing event. So now agents, you can schedule like a Medicare 101 type of event, then wait like a little bit of time, 15, 30 minutes at least is usually good, and then hold your sales and marketing event in the same location. So prior to 2027, you had to give a 12-hour buffer. So basically, you couldn't do an educational and then a marketing event in the same location within 12 hours of each other. Now you can. So again, that stresses what you said, Jen. Prepare now for your AEP marketing plan. I think agents should be lining up those locations where they're going to be holding their events, getting those locked in. Have the strategy. We have to report marketing events to the carriers, of course. So just getting that calendar set with your events is really important.
Yeah, I'm glad you brought that up, Alyssa and Jennifer. And I think that also, Jennifer, you hit on some of the benefits potentially getting pulled back. So that means we're going to need some fresh education and guidance about, if you're going to have a hospital indemnity plan, how do you market appropriately if you're going to be using the different products? Because if the Medicare Advantage plans themselves are going to be a little bit lighter in benefits, then people are still going to have those needs. So it's kind of like what was old is new again, right? We're going to be going back. We're going to be going back to that. I think you've seen that, right, Jennifer? Some of the Hawaii agents were talking to you about that.
Yeah, we had a great webinar, really drilling into, and we can do this here with Advocate, we can drill into each specific market across all 50 states and every county and area, just kind of confirming, which carriers, which products, in those areas would be best served. We've aggregated that all into a nice little system to make it easier. And we have a person, Linda, on our team that's in charge of that. So we're hosting a lot of webinars, and those are all recorded too on our Advocate for Agents site. But generally speaking, that's great. And, back to the scope of appointment, there is a little box on there to make sure you click that one off that says you want to talk with your member about ancillary products. That one should be always clicked off on. It'll be really important going into this AEP timeframe. Also, I didn't mention it before, but the carriers have to have their bids in by the end of this month. Most of them are probably already submitted them in, and just waiting to get a response. And I think that deadline for them is the 31st of May. So as we move through into AHIP and coming out of AHIP, and we're already seeing carriers schedule their local events and putting dates on the calendar, we'll start getting a little bit of information and intel about what is happening with plans. Maybe not very specific, but just in general. So you can look to us for that intel and reading between the tea leaves, as Jacqueline said, to give real-time information to you guys on what things look like. And then just, agents, one thing that you can do is, if as you're talking to your members, just let them know about some of the overall pressures on the industry and what plans will look like, because they won't understand that. They're like, hey, I've been getting, this one benefit for so long. I've been getting a food card forever, or I've had this much dental. And when they see those things change, they typically get mad at the carrier. But we need to be able to explain that. That's not necessarily, it's an industry-wide pressure, right? And I think that agents can do a lot of education to explain that to their members and keep their mind at ease.
Well, that's a good point. Education and setting expectations. If you set proper expectations and you educate appropriately, it'll resolve a lot of complaints to Medicare and a lot of dissatisfaction. Speaking of complaints, Jacqueline, it looks like the HPMS has a new capability with tracking complaints to Medicare. Did you hear that on the call today?
Yes, I did. CMS is starting to now track complaints that they're getting in from members directly to the agent and matching it with the NPN number. So they're starting to track trends across not only agents, but also organizations as well. So I think they're trying to get more visibility and accountability into those trends and, maybe where some of those complaints aggregate.
Yeah, and that's a fairly new capability from what I heard.
Yeah, so they've always sort of wanted to do that. I know they usually address those complaints, with the health plan, and we administer training and things, but they're also now having their own analytical capabilities across that metric.
Yeah, I think that's going to be a trend. One of the things that I always highlight when I'm talking to the CMS leadership is I show them the complexity of someone who's in Medicare and Medicaid and a veteran, because there's multiple levels of coverage in Medicaid. That's a state-run program. Then you got different levels of disability, and so when you quilt all those together, evidence of coverage probably say 250 pages on average. Then you've got all the VA rules. You've got to get all the Medicaid. So whatever decision support tools CMS comes up with, I'm not worried about AI in terms of it displacing any brokers. I hear a lot about that. Um, Changing topics, Alyssa, I'm curious what you think and what everybody thinks about what is appropriate with a plan that doesn't pay commissions. I do expect some news to come out in a few days with CMS regarding that, maybe putting a net in place so it can't be zero, but they can't force a carrier to use or to not use a broker. So I think there's more information. But I see a lot of times when I talk to brokers, some brokers think, oh, well, if it's the best plan, even if it doesn't pay a commission or if it's suppressed, they feel an obligation. And but then I see the other side, which is, there's no service. If they didn't pay it, they don't want you to sell it. So let me know what you're thinking there.
Yeah, that is tough because obviously with plans going non-commissionable, it puts agents in a bind, right? Because they want to do what's best for their client, but also, agents can't work for free. And obviously it it brings up the issue that the carrier makes it non-commissionable for a reason, right? So puts the agent in a bit of a bind because they want to do what's best for their member. I really think it's individual to the agent almost, because I've had some agents say, there's this great PPO plan that's available in this market. It's non-commissionable to me, but it's on Medicare.gov. And it is there and it is available. So, they could assist their member with going to Medicare.gov or calling the carrier directly and having that member enroll in the plan. And that's what I think some agents do, because they really do want to make sure that agents or their members in the best plan for them and their needs. And if that just happens to be a non-commissionable plan for an agent, but it's still out there and available to enroll in. But it also brings back to something we talked about last week, which is that when a plan goes non-commissionable, we've heard that can mean that that plan might not be around the next year. So,
It's a tough one. That's a
it's a
tough
tough
one.
one.
I get
Yeah,
that
for
one all the
sure.
time, and they're almost want me to answer it for them and be their mind on that. It's a tough one. I can, like you said, Alyssa, I see it from both sides,
Mhm.
and you just try to talk it through to figure out the right answer, and it can be a different answer for different reasons for different agents.
Yeah, it's a very personal thing, but I have been told numerous times in very clear terms, if a plan is not commissionable from the plan's point of view, don't sell it. They don't want you to sell it. They've done that for a reason. There's rules about how much they can take benefit structures down or change them to protect the beneficiaries. But generally speaking, the carrier says don't sell it if you're not
Mhm.
getting commission. I do think it's situational and it's personal and there's a lot. So I don't know that there's um, an overall solution that is across the board. But I do think that it takes about 2 years to really stabilize someone in a plan, and you might know more about this, Jacqueline, but, you don't want to move people around. The way that the commissions work, you're not incentivized to move them. It's better for a primary care doctor to have a couple of years to get the meds right and to really get a handle and let the managed sort of care program work the way it's meant to work. So nobody benefits from moving people around. So if the plan is potentially going away in a year, you have to ask yourself, did I really do them a favor if I move them this year and then I move them next year and then I move them another year after that? Because really, we want them to be stabilized. Isn't that right, Jacqueline?
Yeah, that's right. It usually, a new member, including a member that turns 65, the first year is usually unprofitable for a health plan. They're just getting them situated. They're getting their conditions documented. Ideally, they should be having their annual wellness visit, with their primary care provider. So it takes time. The ecosystem really works when a uh, a patient or a client or a member is stable for at least 2 to 3 years, because it takes a village, to really have that stability.
Well, and that brings me to another point. Jennifer, I think you heard some rumblings about some trial programs and activation of benefits. And I've had a couple of agents say, "Hey, I'm so busy at AEP, I'm running back to back to back, for 50 plus days consecutively. I'm not going to have time to add 20 or 30 minutes." Where are you here and there, Jennifer? And I think you're involved in one of those trials, right?
Yeah. Okay. So, there's several carriers looking at this, but they have like these, I've heard it called member activation trials where they're asking the agent to do more than just the enrollment at the time of enrollment to collect more information that's going to be used for them on the health side. This really kind of stems from what we were just talking about earlier, which is the carriers want to move to more of a quality enrollment kind of situation over quantity of enrollments, right? So, I think this is where agents, in conjunction with their support organizations like Advocate Health, can really make a difference in the member experience, in that retention and the overall program. So I think agents should open their mind to do that. I think there's some things that we can do, or the upline. If you're not with Advocate and you're listening to this webinar, your upline or your person you go to can help you with that. But yeah, there's these wonderful programs that they're coming out with. They're a little bit cumbersome and sticky, but they're ultimately asking them to collect different health information, and those things are available on the enrollment tools. And you're going to be hearing more carriers coming out with these kinds of programs. It's more than just an HRA, right? And some of them are looking to pay the agent something for performing this. So, yeah.
Well, hopefully they'll pay the FMO something too, because it's kind of hard to
Well, we are
manage
doing
these
a lot
things.
of work to try to get the information out there. We'll see. It does cost some money to the tops of hierarchy that provide those enrollment platforms. When sales go through there, we don't pass that on to the agent, but so there's a little bit of kinks to work out, I would say. But I think there's been some really good conversations with the health plans and the FMO organizations to try to understand that and look into that. So we'll have more about that.
Yeah. And Jacqueline, to the point of the future, didn't we hear from CMS today that the 2028 rules are pretty baked, and they're expecting the following year to have more regulatory emphasis on quality and the oversight of the carrier onto the FMO?
Yeah, in the 2027 proposed rule, CMS did ask for, a lot of RFI on topics related to agent and broker oversight. And they're looking to, overall improve the integrity of the program and looking for ideas from us, from industry. And some of the things that, I think that they'll, consider for future rulemaking, which they said they will with the responses that they got is, better defining, TPMO umbrella definitions, because right now we all fall under TPMO definition. And I think they're starting to look at like size and scope. I think they, wanted our feedback. So it'd be interesting to see what 2028 mentions. And I think moving forward, they're going to look to that arm to better align, MA oversight for agents and brokers. So we'll see. The 2028 rule should be pretty much drafted, and then we'll see the proposal come out probably like in November of this year, which is crazy that that's going to come up soon. So we're definitely going to keep our eye out on that.
Yeah. And one thing that I learned a few years ago is that when the rule comes out, it's pretty much baked. I used to think that they get the rule and then you get the feedback and they take that feedback in. And they do read the feedback and they do consider it. But generally when the rule comes out, and this is from a very reputable source, someone who was the head of HHS at one point, and the best thinking is already put together. So they can tweak it, and polish it a little bit. But generally they're thinking a year ahead about that. So when you read that paper in November, it's already been worked and it's already been run through a lot of different wickets. And it's actually pretty complicated for how they get a rule out. Well, I can't believe the half hour has gone by. I just want to make one more closing comment and say that the ecosystem and the community-based brokers and the field management organizations that support them, it's a terrific value for Medicare beneficiaries. You think about, $16,000, $18,000 a year. A lot of people live alone, a lot of people in rural areas. They've got access to a quality broker that can help them. And that quality broker has access to FMOs like Advocate. And that is really a terrific value in terms of the economics. It's probably 2 or 3% of the administrative fee goes to the broker, less than 1% to the FMO. So when you think about the efficiency and the value, that impacts earnings per share for the carriers. They can take those improved earnings per share, invest them back into plan benefit structures, and that's a virtuous cycle. They only keep a small amount of profit, 3%, 4%. And so when you think about the whole ecosystem, we have got a lot of people, still almost 5 million people a year turning 65, living longer, living better. And so we actually need more people in the business because there's only so many brokers and they're retiring too. So we actually need to grow the brokers, and it takes years to develop a quality broker. So thanks for all you do, and thanks for listening to the AHA podcast.